HIV no way.
No way.
HIV no way.
No way.
HIV no way.
No way. No way.
Moving with AIGHD
and Jura Foundation,
fighting resistance
of HIV.
Tired and really fed up of HIV AIDS, killing my people every day. 35 million people all over the world live with a virus.
It is true.
If you don't believe what I say, go to your doctor. They will test you. You will know. Blood of my children.
My children.
Is juice of HIV. Flesh of my people.
My people.
Is food of HIV. Tears of my sisters. Is joy of HIV.
Gentlemen, put your hands together for Professor Tobias from Netherlands. Ladies and gentlemen, put your hands together and welcome our doctor, the Deputy Executive Director of Joint Clinical Research Center, Dr. Sise Chitio. Ladies and gentlemen, put your hands together and welcome Dr. Bukulu. Can you put your hands together for the most beautiful young girl living with HIV, studying at Makerere University, third year, Flavia Namuaya. Ladies and gentlemen, put your hands together for my colleague in the struggle, the person I've been working with for quite a long period of time, Miss Asia Russell. She heads Health Gap. We are discussing HIV drug resistance. And I'll straight away go to Dr. Sisi Chitio. Dr. Sisi Chitio, what is HIV drug resistance?
Thank you, Moses. And I'll put this in very lay terms by first giving an example of malaria. Has anybody here ever had malaria? Yes? No? Yes. Do you all know about a drug called chloroquine? Do you still use chloroquine when you get malaria? Why?
Yeah, thank you. I would say we no longer use it because it's no longer effective.
Thank you very much. I think that is an example that is very clear to everyone. When we talk about HIV drug resistance, we mean in simple terms, the drugs are no longer effective against the virus. So even if we take the drugs, they are not stopping the HIV from multiplying in our bodies.
Professor Tobias, what is the cause of this problem, HIV drug resistance?
Thank you. Thank you very much for this question. It's a difficult question, and I'll try to answer it, but it's also a simple question. HIV, as a virus, can multiply very quickly. It makes every 2 days the next generation of viruses in your body. So if you do not take drugs, and if you're infected with HIV, then sometimes more than 100 billion viruses are in your body. And every 2 or 3 days, they create 100 billion new viruses. And new, and new. So it is a large number, very large number. Yeah? And secondly, the virus can change. It changes the way it looks like. It changes how it looks like. It changes its shape. So if you combine that, lots of viruses, and quick changing, then you can imagine that the virus can escape. If you take drugs, then the drugs should stop this and the virus should go down to undetectable. We all know that, isn't it? Viral loads, undetectable is good.
Yeah.
Correct.
Yes.
So that is the goal. If the viral load is undetectable, the virus cannot multiply, the virus cannot change shapes, and no resistance develops.
Wow, that's great. That's good. Dr. Bukulu, do we have people with HIV drug resistance? Are they there?
Thank you very much, Supercharger. The problem of drug resistance is not just an emerging problem. It has been there for a long time. Maybe it has not been highlighted, not just in adults, but also in children. So it's definitely there, if I may answer your question.
Asia, as a community activist, what causes this problem today?
The good news is HIV drug resistance is a problem that can be defeated. When communities support one another to ensure everyone has access to the treatment they need on time and with the support they need. For example, living positively, getting support from your neighbors, your family. We see that when this happens, the risk of drug resistance becomes lower and lower. We have the power to fight together for the conditions to make sure we can achieve undetectable viral load in our communities. So that's the good news. The bad news is we have to work together to achieve that point. One issue we're struggling with right now in the country in public sector clinics is stockouts of medicines that people need to keep HIV low in the body, undetectable in the body. For example, the first line treatment for HIV, very important, powerful combination medicine. So together as a community, we have to ask ourselves, what is causing the stockout? What is causing the shortage? And then we also have to work together, like doctors, to fix that diagnosis, to fix and end those stockouts. Sometimes drug resistance can be caused when people don't have the support that they need to remember, because our lives are really busy. But sometimes we do everything right, but we go to the clinic and the medicine is not there. Is that right? So we also have to fix those conditions that make it so the medicine is not in our clinic. Because every time people take time from their lives to find themselves in clinic, it's imperative, it's a requirement that the medicine also has to be there. It's not only a burden on us and our communities, we also have to ensure that our clinics do their part and deliver the medicine, the viral load testing, which I'm sure the doctors on the panel will describe in a moment, and every other thing that governments and other clinics must provide to us so that viral load is suppressed, the medicines work, and we can get on with our lives as everyone lives positively with HIV.
Thank you so much. Flavia Namoy, have you ever experienced HIV drug resistance condition in your lifetime?
As Madam Asia said, that society, we need support from each other, we need communication. I need support from you, you need support from me. I need you to tell me that I'll be fine. I need you to tell me that these drugs will work. But if you discriminate me, you stigmatize me, then there is no way I'll get the effort to take my drugs every day. I'll start hiding them because you'll be calling me names, you'll be criticizing me, you'll be judging me for a crime I didn't commit, because I didn't infect myself, I just found myself in this status. But if you support me, if I had support at that time, seriously, I wouldn't have experienced drug resistance.
Thank you so much, Flavia. Wow. Straight away, I'll go to our doctor, Sise Kitio. HIV drug resistance. Do we have types of HIV drug resistance? And if they are there, can you please explain to us these? Because today we want to learn them, Doctor.
Thank you, Moses. Do you know how many drugs you're taking? Those who are on treatment.
can use the mic.
You are taking one drug, or are you taking one pill? You're taking one pill, but how many drugs are you taking? You are taking 3. So that is the minimum, 3 drugs. The HIV may develop resistance to all the 3 drugs, or it may just develop resistance to one of the drugs that you're taking. But the result of that resistance is the same. The drugs will no longer work on you. If it is to 2 drugs, and one is the only one working, you are still not having an effective dose because the others are not working. HIV resistance, you know, we take a combination of drugs. And the HIV may develop resistance to one of the drugs you're taking, or 2 of the drugs, or maybe 3 of the drugs you are taking. But the result of that resistance, whether it is to 1 or 2 or 3, it all means that you are taking drugs that are not effective, that are not working on the virus as they should.
Professor Tobias, is it that every person with HIV drug resistance has it because of poor adherence, or there are some other causes that might bring this problem? Is it because that I did not take my medicine properly, or I can take my medication properly? Is there some instances where you take your medication properly, but still there are chances of getting resistance?
This is an excellent question. There are indeed different resistance types. One is called transmitted resistance, and it means resistance that goes from one person to another person. It could be from a mother to a child, or it could be from a partner to another partner. If you're unfortunate and infected with a resistant virus, and you take your drugs properly every day, then still that virus is resistant, and the drugs might not work completely well. So that is called transmitted resistance. It is an unfortunate thing, and it happens in the minority of cases, but it happens. There is also acquired drug resistance. That is resistance that develops over time in one individual because of lack of adherence. Because of side effects, because people maybe skip some pills, or because there are stock outs, or because people are taking also other drugs that interfere. There are many reasons. And so there is acquired resistance and there is transmitted. In other words, the answer to your question is some people indeed, when you're not lucky and you're infected with a resistant virus, can suffer from a resistant virus being perfectly nicely adherent.
Put your hands together for Professor Tobias. We are thankful to Amsterdam Institute for Global Health, who made us possible to have a digital screen for our event for the very first time. Can you put your hands together for Amsterdam Institute for Global Health? Dr. Bukulu, do you have a system that can tell that actually this person's resistance is because of poor adherence? Then this person is because somebody passed the virus to him. Do you have a medical system that can tell that?
Thank you very much, Supercharger. When you say a system, I think that becomes a bit more complicated.
Oh,
but if
a testing or something?
Yes, I'll help you there. So what we do normally when you start on drugs, we start at a certain set point. So one of the ways we check, if you're asking for a system, is using what we call monitoring. And we use monitoring tests, which includes your viral load. But see, the challenge we have is that not every center can do that. That's one of the challenges you face. So it's not just drug stockouts, but can you actually do the routine monitorings? Because it's those routine monitorings that begin to tell you whether your drugs are working.
Put your hands together for Dr. Bukulu. Thank you so much. Asia, as a community activist, of recent we've had their drug stockouts. some clients, some folks of us go to pick medication and they're told medications are not there and they go back home. What is the likely effect of this problem in relation to HIV drug resistance?
Thank you, Supercharger. Thanks, Moses. Unfortunately, when medicines are not at the clinic, it means even if people want to take their medicine on time and have the community support that is so important that was earlier described, they can't take the medicine because it's not in the clinic where it belongs. That's why it's so important that we work together to try to overcome the factors, the reasons behind interruptions in availability of HIV medicines in our clinics.
Thank you so much, my sister, Asia. Straight away, I'll go to Dr. Sise and Professor Tobias. Of recent, you've done an amazing research about this problem, HIV drug resistance. Dr. Sise Chitiu, I want you to tell us something about this study we've had that you have done with Professor Tobias and his team and your team. It's called PESA. What is PESA and where was it done? Because some of our folks don't even know about it.
Thank you, Moses. In collaboration with the Amsterdam Institute for Global Health Department and Joint Clinical Research Center, we've been doing research to look at resistance and effects of resistance in our population. We've had both an adult study called PESA, and PESA was not only done here in Uganda. Here in Uganda we did it in Kampala, Mbale and Fort Portal, where we have JCRC clinics. But this was also done in 5 other African countries, including Kenya, Zambia, Zimbabwe, South Africa, and Nigeria. And in Uganda, we recruited over 700 participants. And maybe some of you were PESA participants. We also had a smaller group of children, about 300 from the 3 sites. And one of the things we looked at that Tobias has already talked about is the resistance in patients who have not yet started treatment. So they don't have history of antiretroviral drugs, but when we checked, we found that they had what we call transmitted drug resistance, and we found it was higher in Uganda than the 5 other African countries. So one of the reasons we are also doing this advocacy here is because Uganda has a higher problem of HIV drug resistance than other countries. And this is due to our history. We started using antiretroviral drugs much earlier than other countries in the region. And if you remember, some of you who were accessing treatment, some patients started taking 1 drug because it was very expensive. Then others started with 2 drugs. But now we know that we have to take all 3 drugs together to have an effective treatment regimen. And we have been following up these people for the past 7 years, the adults. And we have had, we've also had many other results coming out of those studies, plus also the children. And in the children, we found that we had a higher number of, or a higher percentage of children who are starting off treatment when they already have resistance from their mothers.
Thank you. Correct. Uganda was a very important country and is a very important country in those studies. In total, we have studied 3,000 people in those 6 countries. adults and around 500 children, mostly in Nigeria and in Uganda. And we followed them over time, observing what was happening in terms of resistance. And such type of studies are very difficult to do. It takes a long time. It takes years to follow people. You have to build clinics and work with the doctors. You have to get information to everybody. You have to collect data. It is a big, big study. In fact, I think the PACER study was one of the biggest, and maybe even the biggest, coordinated drug resistance study in Africa. At a certain time, 1 or 2 years ago, 25% of all the information to the World Health Organization on drug resistance in Africa was coming from this project. So it is an important project, and the most important issue also is the project already takes such a long time. It's already 7 years, and it is quite unique to have so much information on what is happening. And why do we need this information? Not just to study biology, we need this information to choose the right drugs. Because based on drug resistance, advices can be given to policymakers, to ministries of health, to World Health Organizations, to make the right choices for first line, for second line, and maybe even for third line drugs.
I want to go to Dr. Bukulu to help us. Why is that children will have more resistance chances than adults?
Thank you, Supercharger. That's a good question. If a husband knows that he's HIV positive and his wife doesn't know or he hasn't disclosed, he'll hide the drugs in a convenient place, a drawer in office, at home in a cupboard. But a child doesn't know where to hide these drugs. And the pressures also keep increasing as you grow older. Young adolescents have certain challenges the younger children don't have. Parents will keep giving their children drugs when they are younger, but when you grow older, you have to take those drugs. You go to secondary school, and your fellow students are asking you why you're taking the drugs. And you become embarrassed about it because you've not been empowered or being given enough education. So definitely children at different ages have different challenges. And those challenges expose them to behaviors that will promote drug resistance.
Asia, the issue of viral load, as a community activist who has traveled widely, do people get viral load tests down there?
In Uganda, we need universal access to viral load testing, and we don't have that now. There is new science that shows that CD4 count should no longer be the threshold that determines when someone gets offered treatment. In fact, everyone who's positive, who's ready to start taking treatment for life, should be offered treatment because that saves lives, keeps people healthier longer, and also prevents transmission of HIV. Uganda has the capacity to act on this science and deliver treatment for all as a human right. But to do that, we need tools like viral load testing, like community support, like an end to laws that discriminate against people with HIV. We also need government to prioritize investing. We're right across the street from Parliament. Am I not right?
Yeah. The Parliament is right there.
We need government to prioritize in budget and in political will investments in so much of this work. Good enough, there are Ugandan organizations in the audience. I see Emicol, I see HEPS, I see Nafapanu, so many others, UNIPA, who are working every day to ensure increased political will and accountability from the government of Uganda so that there's more expenditure, so that money from taxpayers is put in investment in viral load, in fighting stockouts of medicines. Because these problems, they are preventable, they can be fixed, but it takes pressure and accountability from everyone in the audience and all of our communities.
Flavia, you had resistance. Have you interacted with some folks of your age who have had resistance? Was the cause of this resistance the same as your cause, or they had other factors that brought about their HIV drug resistance?
Thank you, Supercharger. Yes, I've interacted with my fellow colleagues, and this resistance refers from one person to another. But the main thing is stigma and discrimination and lack of community support. Although there is true adherence and there is also the transmission, what Dr. Tobias talked about, Professor Tobias talked about, from one partner to another and from the kids we give birth to. And since they say that Uganda, we have been on treatment for a very long period of time, like me, I've been on treatment for 15 years now. So you never know what will happen, but young people have had resistance in all categories, transmission, poor adherence, but poor adherence is the main thing, which is brought about by stigmatization and discrimination of them in the society, from the communities we come from the schools we go to, and even workplaces.
My sisters, is joy of HIV. Together we stand as one and fight HIV no way.
No way.
HIV no way.
No way.
Get HIV. But these other clinics that you go on these hospitals, but ku Septrin, at asthma, nakamina Septrin for 4 years. Kati chembuza Septrin yanyamba kuba mina Septrin yeka impekemu. Anyamba na utanyamba.
Oh,
you want to know.
That's a beautiful.
I think gamba. When you're HIV, or you know endala plus Septrin. Thank you very much.
Yes.
Thank you. We have guidelines which we use to determine when to start HIV treatment. And these guidelines have been changing. If some of you remember, before we used to say, if your CD4 is above 200, we will not start antiretroviral drugs, we will wait. But we are going to give you Septrin. And there have been studies that have shown usefulness of Septrin in HIV-infected patients in preventing bacterial infections, diarrheal diseases, even malaria. So the Septrin is effective, and we give it to all people, whether they are on antiretroviral drugs or not. When the guidelines changed, they said, okay, now we are going to increase. If you have CD4 350 and above, we will hold on treatment, but below we will start. Then they changed and went to 500. If you have CD4 above 500, we will hold treatment. And I don't know what your CD4s are, but the healthcare workers or the doctors are following these guidelines. Now the recent guidelines from World Health Organization, anyone who is tested HIV positive, we are no longer using CD4 according to WHO as a guideline. Anybody whom we find is tested HIV positive, we start them on antiretroviral drugs. And we have had many patients in our clinic at JCRC who were just taking Septrin. But now, according to the new guidelines, as they come in or as we call them, they will all be started on antiretroviral drugs.
Just one question. If a person, like for her, she has AIDS, if she's HIV, and the husband has no AIDS, the two of you have sex, finish, but this one gets HIV, no. Why? The other person doesn't get HIV, why? Why does the other person doesn't get HIV if they're husband and wife?
Discordant couples, as we call it. The one is positive, the other one is negative. And the question is about infection. In principle, when the person who is HIV positive, the positive person in the couple, is on treatment, and if the viral load is undetectable, then the virus will never be transmitted. You cannot infect your negative partner because your own viral load is undetectable. Okay? So that's possible. If you have a high viral load, then there is always a chance of infection. The higher the viral load is, the higher the chance of infection. So the message is, if you have discordant couples, one positive, one negative, take the drugs even more adherent, because by being adherent 100%, you kill the virus transmission. It cannot be transmitted to your partner. You stop the epidemic.
Ku kyalo gye tubeera oba kale mu bitundu mwe tubeera oba ewaka oyinza okwekanga nga bakusosola naye bagamba nti olina liira ku fookoyo, olina liira ku puleeti yo, olina liira ku kikopo kikyo, olina kubeera nga buli kimu nga kyokola kikyo. Kwegamba tebaagala kiyalinga naawe bintu simanyi badokita bwe bayinza kumpawulamu kwekyo.
One important point is there are organizations in this audience working to fight discrimination, including wherever they occur, whether at the community level or in our schools or in our churches or mosques. So there is a huge resource, including Nakapano, including HEPS, many others, where I think organizations would really love to learn more about specifically where this discrimination might be occurring in order to follow it up. Because sometimes discrimination is because of ignorance, because people don't have information and they need that education and support so their mind becomes open and they realize, oh, you can't get HIV by touching someone, by sharing food from the same plate. These are not the ways that HIV is transmitted. So it's really important that we respond to those cases when we hear them with that information, with that dialogue, and with that follow-up. So we should make sure to do that before we leave this forum today.
This row, I will give it to Flavia. And it was more a general question again about how to fight stigma. Can you give some practical advice there?
Thank you so much. Stigma and discrimination, I know, reality is it's hard to fight. But our main concern as youth or as everybody living with HIV, the first point is accept. As ourselves, we have internal stigma within us. If I don't accept what I am, then I don't accept the society to accept me as a person. Let us accept ourselves, let us agree that we are positive, and let us think positively, let us have hope, let us take our drugs, then we shall have a better life. And another thing, in our hospitals, in our health centers, let us encourage disclosure by everybody. It is not easy, and nobody is forced to disclose. If you are not ready, it is okay. But remember, if you fear to disclose, stigma will always be on you. You won't be at ease with yourself. Even if you come in a society where nobody knows that you are positive, it's you yourself who is going to destigmatize yourself. You start looking at yourself like, everyone is looking at me. Do they think I'm positive? Do they think I'm like this? It will be on you. So please, I will say let us encourage disclosure, but in a positive way. Let us all stand together. I'll also encourage for the youth in our health centers, let us support youth corners, because as youth, I will find it difficult to talk to a doctor, to talk to a counselor who is 30 about my problems as a person, about the stigma I face. But if you come to the health center and you find somebody like me, I know some youth will be free to talk to me about everything, and as positive people, we are the road to end discrimination and stigma in us. Because if we don't fight back, then we are not going to stop it. But we have to fight back in a very positive way, a way that is very encouraging and a way that is exemplary to even those that are negative. Let them know that society moves in two ways, infected and affected. Thank you so much.
Thank you, Moses. This goes to Dr. Sise and Dr. Bubu. It was proven that when a folk is on treatment, he or she cannot affect each other. Why is it that in Uganda we still have people on safety? I mean, do you feel happy when people are affected?
Thank you so much.
The guidelines have been changing in the country. And right now, the guidelines from World Health Organization, everybody who is tested HIV is started on both Septrin and antiretroviral drugs. Why didn't we do this before? We have also limitations in terms of resources to treat everybody who is HIV infected. And these guidelines have been changing gradually to accommodate more people. That is why I emphasized, please don't go to third line. It is 10 times more expensive than first line. As a country, we don't have enough money to treat everybody, for example, in Uganda, who needs treatment. And our development partners cannot treat everybody. However, as of today, the guidelines have changed. We do not want, and part of those guidelines were also to prevent transmission of HIV, because if someone is treated and their HIV is undetectable, then chances of transmitting to another person are close to zero. So please, those are the new guidelines. Go back to your healthcare providers and let them know, because those are the new guidelines.
Kati ogambye nti muntu asobola okukafuna kali akalaluse manze mmira bulungi kati akansiiga atya ng'ate mmira bulungi ekyo kyenjagala ontangaazemu dokita.
I think that is relatively straightforward. It's like saying if you have flu, can you be affected with malaria? Because a resistant virus is a different type of virus from your actual virus if you have. And I think the question was actually referring that if you have a partner whom you don't know how they're taking their medication, do you have that risk? Yes, it is. There is a risk that someone can be taking their drugs, and when you're not taking your drugs very well, the person who's not taking their drugs very well will develop the resistant virus and will pose a risk to you. That is why medical providers usually recommend protection, use of condoms, even when you know your partner, because you cannot put an 100% guarantee on your partner that they are taking their medications very well. Some of them come to the clinic complaining, my husband comes in, he's drunk, you don't know whether he took the medication. So yes, the risk is there. And you'll always have that risk for as long as your partner, whether married or not married, has a chance of not taking their medications very well, or is not taking their medications very well. I hope that's it.
So yes, this is Professor for you. We are discussing on drug resistance, and you told us that there are some drugs we can take, and they thanks to there are some drugs which can affect the drugs we are taking, thanks to drug resistance. May we know some of those drugs?
I'm not a doctor, I'm a scientist, so I have to be careful here. But basically, there are different types of drugs. Some drugs only need one mutation of the virus, so the virus becomes resistant. These drugs are called low-barrier drugs. Those drugs are a little bit weaker in a way. There are other drugs that need maybe even 3 different mutations before you are resistant. These drugs are high-barrier drugs. Those drugs, for example, are the second-line drugs like protease inhibitors. They are high-barrier drugs. Only you need 3 mutations in the same virus to happen before it becomes resistant. That is a very low chance. So indeed, in terms of resistance, there are better drugs and less good drugs in terms of barriers to resistance. However, the choice of first line and the choice of second line by the World Health Organization and also by the government here has been done in a way that is practically the best. In other words, the highest number of people in this country and in Africa will be on first line. So first line should be cheap, it should be easy to take, and it should have preferably 1 pill per day, like you said, Moses, and it should give as little side effects as possible. The second line, 5 to maybe 7% of people in Africa, maybe 5% are in need of second line today. Those people already, of course, have experienced failure. So here we are in a more challenging situation. the number of drugs increases, as 7 pills per day, 6 per day, antiretrovirals, for example. Also, the side effects can be a bit more. So it is a stepwise process. I am not a specialist in names of drugs and which drugs yes and which drugs no. I should not talk about that. If I would treat you as a doctor, I would, you would have to run very fast.
So my sister, is joy of HIV. Together we stand as one and fight HIV no way.
No way.
HIV no way.
No way.
HIV no way.
No way. No, no way.
Moving with AIGHD
and Jura Foundation,
fighting resistance
of HIV.
Children are weeping, no one to take care of them. HIV has killed most of their parents. No strength, no work, no work and no money, no money, no food because of HIV. I call you my leaders, invest in AIDS to fight resistance of HIV and AIDS. Nsobola, 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 now Nsobola to fight resistance. Nchimanyi Nsobola, 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 now Nsobola to fight resistance. HIV no way,
no way.
HIV no way,
no way.
HIV no way,
no way. No, no way.
Moving with AIGHD
and Jura Foundation,
fighting resistance
of HIV.